After menopause, over half of women experience vaginal changes that make intercourse painful, increase UTI risk, and affect quality of life. Yet most suffer in silence because no one talks about it. Today I'm breaking the silence on genitourinary syndrome of menopause and the treatments that actually work according to medical research. Before we go further, drop a comment and tell me where you're watching from. And if you've experienced any of these changes after menopause, type me too so other women know they're not alone. This affects millions of women and we need to talk about it openly. Important disclaimer. This video is for educational purposes only and does not constitute medical advice. Every woman's situation is different. Always consult with your healthcare provider before starting any treatment, especially if you have a history of breast cancer, blood clots, or other medical conditions. This information is meant to help you have informed conversations with your doctor. Here's what happens in most doctors' offices. You mention painful intercourse or vaginal dryness during your annual exam. Your doctor nods and says that's normal after menopause and moves on. You leave feeling dismissed. Like this is just something you have to live with now. But here's what they don't tell you. This has a medical name. Genitourinary syndrome of menopause, or GSM. It's not just normal aging you have to accept. It's a progressive condition with real treatments backed by decades of research. And the earlier you address it, the better the outcomes. The silence around this topic means that studies suggest 50 to 70% of postmenopausal women experience these symptoms, but fewer than 25% seek treatment. Women suffer for years thinking nothing can be done. That ends today. Let me explain what's happening in your body and why it matters. Before menopause, estrogen keeps vaginal tissues thick, elastic, and well lubricated. The vaginal environment is naturally acidic with a pH around 4, which protects against infections. When estrogen drops after menopause, several changes occur. The vaginal tissue becomes thinner and less elastic. This is called vaginal atrophy. The tissue also becomes drier because estrogen stimulates the glands that produce natural lubrication. The pH shifts from acidic to alkaline, usually rising above 5. This pH change is why postmenopausal women often experience more frequent urinary tract infections and yeast infections. The protective acidic environment is gone. Blood flow to the vaginal area decreases. Less blood flow means less oxygen and nutrients reaching the tissue. Over time, this can lead to narrowing of the vaginal opening. Without intervention, these changes are progressive. They get worse over time, not better. Here's what this actually feels like. Vaginal dryness, not just during sex but throughout the day. A burning or itching sensation. Pain during intercourse, sometimes described as a tearing or burning feeling. Some women avoid intimacy entirely because of the pain. Increased frequency of urinary tract infections. Some women experience urinary urgency or mild incontinence because the urethral tissue is affected by the same estrogen loss. Light bleeding after intercourse because the tissue is fragile and tears easily. And a general feeling that things down there just don't feel right anymore. You might notice discharge or odor changes because the bacterial balance has shifted. These symptoms affect quality of life significantly. Research shows they impact sexual health, intimate relationships, self-esteem, and daily comfort. Yet women hesitate to bring it up because of embarrassment or because they think nothing can be done. Both of those barriers need to end. Let's talk about what the medical evidence actually supports for treating these symptoms. I'm going to go from most conservative to most effective based on research. Option 1. Vaginal moisturizers and lubricants. These are over-the-counter and hormone-free. Vaginal moisturizers are used regularly, typically 2 to 3 times per week, whether you're sexually active or not. They help maintain moisture in the tissue. Water-based lubricants are used during sexual activity to reduce friction. This is the first step many women try. They can provide relief for mild symptoms, but they don't address the underlying tissue changes. Option 2. Vaginal dilators and pelvic floor physical therapy. If tissue changes have caused narrowing or tightness, vaginal dilators used gradually can help maintain or restore vaginal capacity. Pelvic floor physical therapy with a specialized therapist can address muscle tension that sometimes accompanies vaginal atrophy. Many women develop protective muscle guarding because of pain, and PT can help release that tension. Option 3. Low-dose vaginal estrogen. This is considered the gold standard treatment by major medical organizations, including the North American Menopause Society. Low-dose vaginal estrogen comes in several forms. Creams applied with an applicator. Tablets inserted into the vagina. A soft flexible ring that releases estrogen continuously and is replaced every 3 months. Here's what makes vaginal estrogen different from systemic hormone therapy. The dose is very low. It acts locally on vaginal tissue with minimal absorption into the bloodstream. Research shows it effectively reverses the tissue thinning, restores the acidic pH, improves lubrication, and reduces UTI frequency. Studies indicate that low-dose vaginal estrogen is generally considered safe even for many breast cancer survivors, though this should always be an individual decision made with an oncologist. The systemic absorption is minimal. This is not the same as taking oral estrogen or using estrogen patches. Many women see improvement within a few weeks, with continued improvement over 3 to 6 months. It's typically used long-term because symptoms return if treatment stops. Option 4. Newer non-hormonal treatments. For women who cannot or prefer not to use estrogen, newer options exist. Vaginal DHEA is a hormone precursor that can be converted locally to estrogen and has shown effectiveness in studies. Ospemifene is an oral medication that acts like estrogen on vaginal tissue but not on breast tissue. It requires a prescription and has specific considerations. Laser treatments and radiofrequency devices are being studied. Some research suggests benefit, but these are still considered emerging treatments. They're expensive and not always covered by insurance. Evidence is still building on long-term effectiveness. Here's what you need to know before choosing a treatment. First, talk to your doctor about your complete medical history. Women with a history of certain cancers, blood clots, or liver disease need individualized guidance on which treatments are appropriate. Second, don't wait years to address this. The longer vaginal atrophy progresses without treatment, the more tissue changes occur and the longer it takes to see improvement. Early intervention generally leads to better outcomes. Third, you may need to be persistent with your healthcare provider. If your doctor dismisses your symptoms or doesn't offer treatment options, it's reasonable to seek a second opinion or ask for a referral to a menopause specialist or gynecologist experienced in treating GSM. Fourth, combination approaches often work best. Using a vaginal moisturizer regularly plus a lubricant during sex plus low-dose vaginal estrogen can provide comprehensive relief. The bottom line is this. Vaginal changes after menopause are common, but suffering in silence is not necessary. Multiple effective treatments exist. You deserve to be comfortable in your own body and to maintain intimacy if you choose. If you found this information helpful, please share it with other women who need to hear it. This is a conversation we should be having openly. Hit that like button and subscribe to the Sarah Mitchell channel for more evidence-based women's health content. And drop a comment below. What's one question about this topic you wish your doctor would answer? I read every comment and your questions help me create content that actually serves you. Remember, your health matters. Your comfort matters. And you have options. Don't accept dismissive answers. Advocate for yourself. You deserve care that addresses your quality of life. Subscribe. I'll see you in the next video. Take care.